Mm. None of your fucking business. Pray Bruno Mars on YouTube. Play relaxing sounds. Play relaxing sounds. Okay. Play Bruno Mars.
Here's 15 hours of deep separation anxiety music for dog relaxation. Helped 4 million dogs worldwide. New.
Hey, I'm Talon, and this is Ruckus, and I'm going to show you how to start an online t-shirt business. Let's go.
Play Neurosurgical TV.
And start a free trial. Next, create your t-shirt. You can use your own designs or hire a freelance designer. Once you have a design,
Oh. Hey, Asadea.
Hey,
All right, well, you're up late, huh?
yeah.
Okay,
Sorry for that.
okay, I'm gonna make you co-host so you can
Okay, thank you.
mute. Okay, so you can mute people. I do need the help if you can pay attention. Okay.
Okay,
Okay.
that's okay.
Okay, there you go. Okay. Yeah, you look better in the first commercials.
Really,
Yeah, I
that
think
was
so.
good.
Yeah,
Thank you.
because it didn't look like you were made up. Like, you know what I
Yeah,
mean? And it looked
yeah.
more
I mean,
natural. And I think it's better you dress in a lab coat.
okay, okay.
Yeah, like professional, you know.
Thank you. Okay,
Yeah,
that could be better.
yeah. We'll try it that way.
Okay,
You know, rather than someone that's just doing the webcast, but someone that you know, a scientist. That's part of
Yeah,
it.
I know.
Part of it. Okay.
That's okay.
Okay, I'll be back. Hello, everybody.
Yes, sir. Hello, how are you?
Hey, Ahmad. Is that Ahmad?
Yes, sir.
Okay. Okay, just getting set up. There you go. That one. Oh, I got my YouTube on. I do have it on. I gotta turn it off. Yeah, yeah. I think somebody else has a YouTube on.
Has a YouTube on connected to your?
Yeah, somebody has a YouTube on. Yeah. Here's Lee.
Yes, sir. Yeah, there he is.
Ahmad, do you have any artificial intelligence going on in Arkansas?
I didn't hear of, but for sure they have.
Okay. Because we have someone here that's working with us to try to get artificial intelligence in neurosurgery going. How's the day? You there?
Hi. Yes, I'm
Yeah,
here.
yeah. I'd like you to meet Ahmad.
Okay.
Yeah, he's a doctor at Arkansas Neuroscience Center.
Oh,
And
glad to meet you.
hello, Ali.
Hey, John, how are you?
Good. How you doing?
Good.
Ahmad's here.
Yeah.
And Dr. Lee, are you there? Right?
Yeah, I'm here.
How are you doing?
Very good. How are you?
Let the residents know the app is in full. It's working good, I think.
Oh, okay. Great.
Yeah, you're on the front page. This conference is on the front page. So once you download the app, you tap it once, and you tap it again. Hold on. I'm opening mine now. You tap it once, and then you tap it again, and then you're in. You're into the conference with 2 taps with a
Okay.
finger. It's not typing, it's tap,
I see.
which is immeasurable. I mean, when you get people to try stuff, tapping the finger is a lot better than typing.
Okay.
Hi to all.
Hello,
Hello. How are you?
Ahmad.
Hey,
Who,
hello. Hello, Omar. How are you?
Alhamdulillah. How are you? Thanks God. How are you all?
Very well, very well. How is the weather at your end?
It's cold today. Too much flowing.
Oh, windy.
Mhm.
Windy.
Okay, windy.
is it hot?
No, he's saying cold.
Cold. Oh, okay. It's March.
Tonight it's cold.
Oh, okay.
What do you mean March? It's April.
That's right. April snuck up on us. Oh, let me take my pin off. That way it goes all over the place. So we're just waiting for Michael, right? Yeah.
I will try to get in from my other computer, so I might leave. Okay, Michael. John.
Hello, testing, 1, 2. There's no sound. What's going on? Can you guys hear me?
Yes.
Oh, okay.
Oh, you mean there is no chat between people, huh?
Oh, okay. There was, oh, I'm sorry. What'd you say, Ahmad?
Everybody is waiting for the.
Oh,
Yes,
okay.
but-
Okay. We're waiting for Michael, right?
Yeah, here are they, both Professor Krisht and Professor Lawton. Both are here.
Oh, good night, everyone. Hi, Professor.
Hey,
Hi,
hello.
Professor. Ahmad.
Hey, Professor
Hey,
Ali,
yes.
how are you?
Welcome.
Good, how are you? Hey, Michael.
Professor Ali, how are you?
Good, good, how are you?
Sounds good, thank you.
Hi, Ali.
Michael? Hey, Michael, welcome back. Yeah. Mhm. Mhm.
There's Michael.
Okay, just get it. That's fine, no problem. Yeah, yeah, that's fine. All right. Oh, okay, bye.
Okay. You guys ready to start?
Yep.
Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good evening from Miami Beach. It's Dr. John Bennett for Neurosurgical TV. It's a great honor to be hosting the series of 6 broadcasts of achieving mastery in aneurysm microneurosurgery with Ali Krisht and Michael Lawton, who both gentlemen don't need an introduction. I'll just start right off with Ali. Welcome, Ali. It's all yours.
Thank you, John. Welcome, everyone. And for those who are coming back, welcome back. And for those who just joined us, this is our 6th session. This was a series of lectures that we have given, myself and Michael, Dr. Lawton, on the different types of aneurysms, kind of derived from the spirit of his book, 7 Aneurysms. Today we'll be discussing the last 2 aneurysms, the PICA, posterior inferior cerebellar artery aneurysms, and the pericallosal aneurysms. For those of you who did not have the chance to watch those before, you can go to Neurosurgical TV and they're all there and you can watch them. It seems like it's been well attended and viewed over the last few weeks, I noticed. And today's session will kind of address these 2 aneurysms. And like we have been doing, Dr. Lawton will start and present his approach to them, and I will also give my take on some of them. I think I have read his book, and I think a lot of what we're gonna say is gonna overlap. So I tried my best to not include things which are nicely shown in his book that I'm sure he will be covering, so that we can use as much time to show cases. Michael?
Okay, Ali, thank you. Let me go ahead and get my screen share going here. Okay, so you should have my title slide up there. You have
Yes. Yes, perfect.
Okay, great. Well, I just want to just preface my talk by saying this has been a nice series. Ali, thank you for being the inspiration for this. I needed a little bit of a push and you gave that, so I'm glad you did that. Hopefully all of you out there have enjoyed this. It's been a pretty good tour of the 7 aneurysms, and this is the home stretch. So we're going to talk about what I think is one of my favorite aneurysms, the pica aneurysms. I like them because, as this slide shows you, the anatomy is incredibly beautiful. It's very complicated. It's a very elegant approach that we use with the far lateral to get there. And these aneurysms are really highly variable. It's one of those aneurysms, not like PCOMs or MCAs, where they're pretty much, they fall into some pretty simple groups. These pica aneurysms tend to be really different, very dysmorphic. very non-saccular. So I think it just keeps it interesting down there. So let me just go through some basic anatomy to start. These are the different segments of pica. I think it's important just to think in terms of your segmental anatomy because it helps orient you and it helps us communicate more precisely about where the aneurysm is, where exactly it is in relation to the cranial nerves. These are the segments. The first segment begins at its origin from the vertebral artery, the V4 segment, which you see here. It goes all the way to the pre-olivary sulcus here, where the 12th nerve comes out. The second segment runs from the pre-olivary sulcus to the post-olivary sulcus across the olive, and is between these two layers of cranial nerves, the deep one being the 9, 10, and 11, coming out of the retro-olivary sulcus. The third segment is the tonsillomedullary segment, which contains the caudal loop here and extends all the way up to the midpoint between the caudal loop inferiorly and the cranial loop superiorly. It's an arbitrary point. This fourth segment, the tilo-velo-tonsillar segment, runs up and over out to the biventral fissure where it comes out on the cortical surface and becomes the fifth segment, P5. So those are the 5 segments, and here's just another view. Again, showing P1 here in the front, P2 going across the nerves, P3 heading into the caudal loop, P4 into the cranial loop, and P5 coming out on the cortical surface. Now, one of the things that I think is really helpful when you think about pica aneurysms and just this anatomy in general is to think of your triangles. This illustration shows you the vago-accessory triangle, which is defined by the lateral border of the medulla, the inferior surface of the vagus nerve, and the medial border of the 11th nerve. So this triangle here is the route that you take for virtually all of the aneurysm work that you do through the far lateral exposure. And when you think about this triangle and its relationship to 12, which is always draped over the V4 segment, 12 bisects that triangle into 2 roughly equal spaces, the infrahypoglossal triangle and the suprahypoglossal triangle. So there are 2 spaces within the triangle, and this can help you kind of organize your thinking about where you're going and the angles and the trajectories and so forth. Now, the 12th nerve isn't always in this nice, neat bundle. You'll sometimes see the rootlets of 12 spread apart. So there's actually a hypoglossal triangle. This is an oversimplification, but if you have the splay of the 12th nerve rootlets, you're going to get a 3rd space within the vago-accessory triangle between the rootlets of 12, and that's yet another triangle. Now, those definitions that Lawton gave us, defining the anterior medullary, lateral medullary, and tonsillomedullary segments, I like to think of those in terms of the different zones going from superficial to deep. And if you think about the tonsillomedullary segment, that P3 or 3rd segment, that is relatively superficial. You're outside of the nerves and it's easy to get there. And as you go from tonsillomedullary or the green zone to lateral medullary or the blue zone, the anterior medullary zone, the red zone, you're going progressively deeper to the nerves. And you can see how you're behind the olive here, across the olive here, and in front of the olive here, finally in the anterior medullary. And so since we're coming at these things from out here, our perspective is one of a progressively deepening lattice of lower cranial nerves. So this is a helpful way to think about it. Here's another perspective, the axial perspective, just showing how if you're starting out here in the white zone, you're going from green to blue to red, and you're deepening as you go from one to the next. So as you enter those triangles and you go into the subtriangles, you're going progressively deeper and deeper. Now, this is also another way to think about your aneurysms, your pica aneurysms. The aneurysms can lie in the suprahypoglossal triangle, and that's the most common position. But if you have an aneurysm here between the rootlets of 12, it's going to be in this hypoglossal triangle here. You can also have it in the infrahypoglossal if it's a very early origin of pica. It will come off in this very early segment and get itself positioned here in this infrahypoglossal portion. And then this last example here is if it's completely outside in that tonsillomedullary zone, it's not within the triangle at all. And oftentimes those aneurysms are fusiform or dysmorphic, and those are the ones that often require a non-clip strategy. So this is yet another way to use these triangles and these definitions to kind of think about the pathology a little differently. Now, it really doesn't matter what of those different variations of aneurysm you see, because they're pretty much all dealt with this far lateral approach. It's a beautiful approach. I think the whole secret is that you really want to be looking down the barrel of the V4 segment. And to get that perspective, you got to basically turn the head upside down and be looking downhill here. And the way we do that is the position of the patient. So the far lateral approach is so important to have the right head position for that, because this is the view you want, and you've got to get the head positioned properly. If you don't, then you're fighting the anatomy the whole way through. So the position is a 3/4 prone position with the arm hanging over the end of the table. And there are 3 motions. It's flexion, rotation, and down, which means you want the chin to the chest, you want to rotate the head downward, and then you want to tip the vertex down. So you're essentially bringing the mastoid process to become the highest point in the field. And that's really your landmark. You want to be looking right down that, that little corridor from the mastoid tip downward. This illustration here shows you the hockey stick incision, the craniotomy, and the C1 laminectomy. So those are the 3 key components here that go into the soft tissue and bony exposure. Here's just the skin incision. The landmarks for this is actually not very well drawn, but it's a midline incision. And with the head turned, like I just explained to you, you can very easily get off midline. So you want to either mark it before you turn or very carefully palpate for these spinous processes and make sure that you're in the midline. The tip of the mastoid is your other landmark, and then the line of the transverse sinus is the superior nuchal line, which runs from the external auditory canal to the inion, and it's usually a straight line. It doesn't really do you much good to go above that because you're just flipping this extra tissue here. So I usually just straight line that across and head down the middle. The portions of the exposure beyond the laminectomy and the craniotomy are shown here. I like to first cross the midline here. So even though this is a unilateral exposure, I like to get across the midline so that I can open that dura pretty much in the midline and then head over to the lateral portion here. So I take a little bit of bone here at the midline. I also like to get all the way down to the edge of the sigmoid sinus. So that often means taking this little corner of bone off. And then lastly, most importantly, is this condylectomy. You've got to take out the condyle in order to get that corridor open. And I analogize this to the pterion. It's like the angle between the temporal lobe and the frontal lobe is filled with pterion. And unless you get out that lesser wing of the sphenoid and drill that flat, you're not going to create the space to look down the sylvian fissure. Well, the exact same situation is true here. If you don't remove the condyle, you're not going to get the space to look into that angle between the tonsil and the cerebellar hemisphere on this side and the spinal cord over on the other side. So you've got to really aggressively take that out. And what that does, it just gets rid of the bone and allows you to steepen that view so that when you're looking along the skull base, you're following that V4 segment and you're getting an unobstructed view with room to work. So here's the craniotomy. I think the little secrets for this are just when drilling the condyle, I like to use a diamond drill bit. I like to kind of cavitate the bone leaving the outer shell to protect the dura and all the veins that are around it. So if you do that, it makes it much more clean and bloodless. So it's a nice way to do it. And again, you want to look at this angle between the dura of the spinal cord as it kind of goes around to the front, and this curve of the dura here under the cerebellum, and really open up that space as widely as you can. And that means drilling kind of away from that angle, pushing yourself into the condyle. And the rule of thumb is when you think you've drilled enough, keep drilling, because there's always more. The landmark that warns you that you've gone too far is the hypoglossal canal, but it's so rare to be able to get that far forward that you just drill until you feel that angle opening up, and there's usually some emissary veins that will chase you away long before you ever reach the hypoglossal canal. So in the end, you get this beautiful exposure, which you see here. The condyle sits in this space here, and you can see that when you've done a thorough condylectomy, that space is open. And not only that, when you think of the dura pulls flat so that there's no angle here, there's no protuberance of bone. This should be completely flat so that you're looking right down the barrel of V4, which, as I said at the beginning, that's really the objective. Now, you could do this with a mini far lateral. The mini far lateral is really just a simpler skin incision. It's what I call the lazy S. You want to get yourself over to the midline here at one end of the S, and you want to get yourself over to the transverse sigmoid on the other end of the S, and in between is this kind of vertical incision. And that is a really nice shortcut for a simple lesion. It's straight through the muscle. It's quick to open, quick to close. I think it's a little bit more narrow. I don't like it for complicated aneurysms. And actually, you know, the hockey stick incision is so beautiful because you get that avascular midline nuchal ligament, and you've got the superior nuchal line. It's a really nice way to do this dissection, but it does involve a lot of muscle movement. So if you're looking to minimize that, the mini is an alternative. So this illustration shows you just how straightforward pica dissections are. There's no fissure split. You just open cisterna magna. You gain proximal control of the vertebral artery just by sectioning the dentate ligament where it attaches to the dura. It's completely white. It's not off-white. You have to make sure that you differentiate that from 11, which is running parallel to the dentate. But the difference in color is unmistakable. And when you cut the dentate, you've got a nice exposure of the very proximal V4 segment just after it goes through its dural ring. And the dissection is really just two moves. You're going to follow the V4 segment distally, and you're going to find the caudal loop and follow pica distally. And the two of those converge on the aneurysm, and they converge on the axilla of the pica as it originates from V4. So the aneurysm is away from you. So you don't have to worry about intersecting the dome or rupturing the dome. You're on the safe side of these arteries, and so it'll take you there in a way that's really uniquely safe. Once you've got that, then you've got the aneurysm should be in view, and then it's a matter of doing your dissection, freeing the dome up from its adhesions medially to the medulla, freeing your dissections laterally to the adhesions to the dura or the other nerves, and then you know, you can begin to think about your clipping. This was intended to show just the unruptured case. This is the ruptured case, or sorry, this is the suprahypoglossal triangle. This is the infrahypoglossal triangle. The concepts are the same. You're using the same landmarks to get there regardless. So it really almost doesn't matter, but this is an easier dissection because it's more superficial. Now, one of the things that I like to mention here is, you know, we published on this a while ago, but if you have a patient that presents with a subarachnoid hemorrhage and a 6-nerve palsy, you should know just from your bedside acumen that that's a pica aneurysm, because there really isn't any other aneurysm that does that. And it's like the PCOM with the down and out pupil. That is a bedside finding that tells you that you're dealing with a ruptured PCOM. The sixth nerve palsy is a bedside finding that tells you that you're dealing with the ruptured pica. And the reason you get a sixth nerve is because not because the aneurysm is compressing the nerve like it is with the PCOM and the third nerve. You don't see 6 anywhere in this diagram here, but it's because these aneurysms are projecting superiorly, and it's that rupture and jet of blood that intersects with the nerve that damages the nerve. And so that's the reason for it. And when we published this, we noticed that it wasn't an ipsilateral third. It wasn't an ipsilateral 6. It's sometimes a contralateral 6. And that's because sometimes these aneurysms will project superiorly, but also a little bit towards the midline. And the jet of blood will hit the nerve in a cross-court manner. So the side isn't necessarily localizing, but the finding of the sixth nerve is. As far as clipping is concerned, here's the standard kind of tandem clip construct with a fenestrated going around pica and a straight clip closing the fenestration. This is a nice way to do it. Let's move to some cases. This is a case, you can see a fairly simple, straightforward one. Right down here, you see a small saccular aneurysm. And this is just to show you a pretty routine, uncomplicated one. You can see the far lateral exposure. You can see the beginning of the dissection here. The 11th nerve is down in the gutter here, and that's the real important finding. 11 will always orient you. It'll always run the full course of the surgical field, and it will lead you to 10 and 9. Here's just opening the arachnoid. We're now entering the vagoaccessory triangle. You can see pica coming through the nerve rootlets. And as we enter the triangle, you can see that pica leads you to that convergence. There's the pica here. Here's the V4. There's our convergence. It takes you right to the aneurysm. And this is a beautiful, superiorly projecting saccular aneurysm, nice, simple neck. And you can see working through the triangle, we've got full visualization. We can see the blades nicely. And you know, these couldn't be easier. It's a quick dissection, particularly in these unruptured cases. You can see everything. Cisterns are clean. You can protect the nerves. There's just a little remnant here at the neck right there. So we can deal with that with a little understacked clip going on here. And this is just to make the point. A good far lateral will get 90% of the work done. Then it's just a matter of opening up the cistern and finding or following your landmarks. You notice there, I do often use a little retractor on the tonsil. The tonsil is one of those things you can easily retract with not much of a concern. So it's a good thing to use just to kind of pull the tonsil up and open up that vagoaccessory triangle.
Circle of Willis.
So here
you can see the dense packing of blood.
Here's an unusual case, subarachnoid hemorrhage case. When you look here, this is a extradural origin of pica and a very low riding. It's actually an extradural pica aneurysm. You can see the C1 sulcus is here. This comes off between C1 and C2, and the aneurysm is down here, very low, below the typical location of a pica. So this is just an unusual variant that I thought I'd show you. Here's the hockey stick incision, the 3/4 prone position. And here now is the exposure. Again, subarachnoid hemorrhage case. You can see as we open up the cisterna magna, the cistern here is completely packed with blood, so we have to carefully excavate. So the cisterna does take a lot of blood, so when you have a rupture, you can very often have these clots accumulate here. But here you can see this is cutting the dentate, open things up, brings our vertebral artery into view. Here's pica. Whoops.
Or angiogram, laminectomy,
Sorry about that.
or angiograms demonstrate this, which is a nice.
So sorry about that. So here's that pica coming through. So this is the proximal pica as it comes through the dura here. Our aneurysm is over here. And this is one that I wasn't sure that I'd be able to clip. You can see sort of a corkscrew artery. This is the efferent vessel coming out. The afferent vessel coming in is over here, but you can see there's actually a neck. Here's the C2 nerve root. And our aneurysm, as we look between the roots here, is underneath C2. That's how low this is. But we're going to put a temporary clip, which will soften the aneurysm. This allows me to be more aggressive with the sac, and you can see our clip goes right across that neck. This is our outflow artery. This is our inflow. We just line the blades to connect the two, and now we can come off with the temporary clip. The aneurysm is excluded. This pica is nicely reconstructed here. And as we look at the aneurysm itself, you can see it's dead. No pulsation in the aneurysm. Here we're just incising to puncture. There's a nice view inside the aneurysm. So here the dome's going to come out. And here's our view of the reconstruction. It forms this 360. Here's our angiogram, indocyanine green angiogram showing good flow. And it's a nice reconstruction there. So anyway, very unusual aneurysm. Again, goes along with this theme of there being this variant anatomy. Here now is what we often see, these fusiform morphologies here. This one you can see here on the CTA, there's an inflow over here, an outflow over here. This is one that did not lend itself to clip reconstruction. So we're going to do a pica-pica bypass. And I'm going to just jump forward here. Sometimes you get these occipital sinuses here, just showing here some wet clips to manage that. But now we get down here to the cisterna, and we have a nice view of the pica vessels here. And what's beautiful about the pica-pica bypass, as you can see it, the picas are completely parallel here in their caudal loops as they come out of the caudal loop. So it's a real nice way to bring these together. They naturally touch one another, and you can now perform your bypass with the intention here of then trapping the aneurysm. So here, I'll just accelerate here since time is limited. But we put our clips on, we make 2 linear arteriotomies. The caliber of the vessels here is real nice. You can see it's really important to have done your dissection so that these arteries naturally come together. This is teno sutures, so you want the arteries not to be under tension. So these first 2 stitches, these anchors, are really important to bring everything together. And then here, this is just an example of the entrance stitch, which brings your needle to the interior. And now you see these 2 intraluminal layers here on the back that come together with a running continuous stitch. And that brings the back walls together. We then bring the front walls together with our second suture line here. And now you can see we've got this nice communication. The one side will feed the other. The contralateral pica becomes the donor. And you can see you want that arteriotomy to be 3 times the diameter. So there's a good long anastomotic connection here. And now we can go to our aneurysm itself. So here, I'm just going to clip this aneurysm. as if it had a good neck. And it doesn't matter now. This clip didn't preserve the flow in the pica origin, but we've got our bypass in position, aneurysms occluded. Up in the upper left here, you can see good patency of the graft and good filling of the pica all the way back to these perforators where the arrows are. You can see that they're little medullary perforators, and there's flow through pica retrograde that takes care of those. And if you look at the medulla here, all those perforators light up beautifully from our revascularization. So that's an example of a pica bypass. This next one here is going to show you a pica reanastomosis. Again, these are all far laterals. This aneurysm has this fusiform shape, as you can see here, and subarachnoid hemorrhage. You can see the blood in the cisterna magna here, and this is our aneurysm. So there's our aneurysm. We're going to just excise this thing. Comes out very nicely. By excising the aneurysm, you can see that we have two workable ends of artery. It's just an end-to-end reanastomosis. And with these, you know, the pica vessels can rotate a bit. So you place your wall, and then you can kind of rotate the artery by moving the temporary clips downward. And that brings the back wall forward. And you can see, again, a running continuous suture, sequential tightening. And this is a really nice way for a reconstruction. It doesn't involve the contralateral pica, so it's a little bit safer, and it's a really nice option. This is another pica, so I think I'll skip that. And I'll just show you one more aneurysm, just because some of these aneurysms are not all picas. They can be on the vertebral artery. So here's an example. This aneurysm you see here, the pica is actually distal to the aneurysm. Sorry, proximal to the aneurysm. Let me go back and show you that. Here's the pica origin there, proximal to the aneurysm. And here's our exposure. Far lateral approach, opening here the arachnoid of the cisterna. And as we come in, you can see very nicely this glistening dentate ligament right here. Here we cut the dentate ligament. That gives us exposure to the V4 segment for proximal control, and it also brings the aneurysm into view. Here's the 11th nerve running vertically. The 12th nerve rootlets are running across the aneurysm, perpendicular to 11. And pica, you can see there, it's originating from V4 proximal to the aneurysm. Here's that little tonsillar lift. It gives us a little extra room. And here now, everything's in view. So for this one, I'm going to show you the crosswise tandem clipping. And here, what you see is there's not a lot of working space here between the lower cranial nerves. So what we're going to do is we're going to soften this aneurysm with a temporary clip, which goes on here. We're going to work the nerves off of the fundus of the aneurysm, and we're going to just use this central region here as our working space. So our first clip is a 45-degree angle fenestrated. The fenestration is going to encircle the V4, and if you watch the tips right in here, they're going to go all the way to the clival dura. They're going to get across the proximal neck, but the heel is only about halfway across the neck of the aneurysm. So we're using this first clip to just close the proximal neck. And you can see we're working between 11 here. We're working between one of the rootlets of 12. And that takes care of half of the neck. Now, this next clip is going to be exactly the same clip, but it's going in the opposite direction. The blades now point up towards the tonsil, but we're going to go underneath the blades of that first clip. We're going to go heel to heel with the toe pointing forward. You can see the toe is past the neck distally. And these overlapping crosswise clips are going to address the neck. So now our temporary clip can come off. You can see the aneurysm is very pale and static. We do our angiogram here. You can see pica filling here. You can see the vert filling here. There's no filling of our aneurysm. And this Yellow 560 is a nice way to check perforators. You can see those perforators a little bit more brilliantly with the yellow, and this confirms that all looks good. So here, just to wrap this one up, you see the puncture of the aneurysm to confirm that it's officially quiet. So let me wrap this up. You know, I think that with pica aneurysms, you have to have bypass sort of in the back of your mind. Not all of these aneurysms are clippable. The illustration on the left shows you the aneurysms at various segments of pica from P1 to P4. I've seen them all. You can bypass any and all of these. You can't clip all of these, so you have to have these options ready. You can see you have the most options for the P2, but there are plenty of options between pica-pica, between reanastomosis and reimplantation. I haven't shown you reimplantation, but you can cut the pica off of the aneurysm and reimplant it on the proximal V4, and that's another nice way. You can also use the V3 segment extradurally as a donor and do some jump grafts. Really lots of options here. So it's 4:34 on my clock, so I think what I'll do is stop here and turn this over to Ali.
Thank you, Michael. That was a nice overview. So I will, Michael covered the pica very nicely. I'll just mention maybe a few things that could be helpful to some of the audience in some cases, and then maybe I'll skip my most of what my talk is on pica, and then cover some aspects of the pericallosal aneurysms. In this way, we've covered most of the aneurysms. It's interesting when he showed the different proximal, middle, and third distal part of the vertebral artery. This is how I view them, and I view pica as either proximal or middle or distal. This is an example of it where it's kind of quite distal. Close to the vertebrobasilar junction is where the takeoff is. Those are mostly anterior to the brainstem in a way. And another thing to notice is that pica tends to be coming off the neck region of the aneurysm. You can see it here, so it's important when you're putting your clip, like you've seen nicely shown, that you skip the takeoff of the aneurysm, of the pica. This is usually the surgical view. You come to pica before you come to the aneurysm. And again, this shows how it is taken off at that junction of the aneurysm. So it's very easy to kind of compromise the flow in it. You want to make sure 100% that it's good flow post-op. Yeah, this is, some of them are even a little bit distal in location, like you've seen here. They're easier to clip in a way. And still, no matter how small pica are, don't underestimate them. You can see the extensive hemorrhage in these cases. I take them very seriously. They're aneurysms that like to bleed in a way. Michael mentioned how dysmorphic they can be in many cases. And sometimes they are distal, as he showed. And in our series, about 50-50 in a way in terms of ruptured and unruptured. Again, he showed cases like this, which is very dysmorphic at different levels. They're also commonly associated with cases with AVMs, which are fed by pica. They're prone to develop aneurysms, like in those couple of cases. Another thing is, in about 40% of our cases, there was other aneurysms. They're very common with multiple other aneurysms in their location. That mentioned they're common with AVMs. This was, we kind of published this in 2005 about our strategies, which is very much like what he described. We divided it into 3 sections. It's interesting that I'll show this. This is how the view is, and this is the view you want to get for these approaches. And that's the approach, and I'm not going to dwell on it. Michael mentioned very much how it is. Now, if we look at them, this is the different types. The A is the most common location, which is in the middle part. The B is the proximal ones, and the C are the distal ones. And as Michael mentioned, sometimes the proximal go down to the spinal canal. This is an interesting picture. I've actually talked with Professor Yazagil about it once, because he used to do a very limited approach. This is from his book, and he showed this picture where he retracted, and you can see it. However, this is enough only when you're dealing with the middle ones. The more distal ones or the more proximal ones, they really need, as Michael mentioned, they need the condylar drilling to see the proximal vertebral artery. And this is the most common type, the middle one. The approach is kind of limited craniotomy. You don't have to do much. He mentioned it. And this is what the view you want to get. This middle one is usually in this location, not very proximal and not very distal. The other ones, this is an example of it. And I think, like Michael said, these are nice aneurysms. A lot of times they're in front of you. And I'll speed this up. He showed very nice videos, but look at the view through which it's very important to be very gentle with those nerves. It doesn't take much for patients to have difficulty swallowing. But look at the takeoff of the pica, how it is incorporating part of the aneurysm. That's why you have to visualize it very well when you're putting the clip. And in this case, you can see that we're looking at both sides and preserving the takeoff, because you can easily be fooled that this is part of the aneurysm. And that's kind of a message you have to keep in mind. But nowadays with ICG and microdopplers, you can easily visualize them. You can see both sides of it, have a good exposure with it, so that by the time you finish, you're visualizing everything on this. Look at the proximity of the takeoff of the nerves here. You see that nerves? This is important to realize that you can easily injure those nerves when you are trying to do, and that's the final view of it. I'll skip that, and I'll skip this also, and it's all shown nicely by Michael. Again, I'll skip this. And I'll skip this case too. And he showed a lot of nice cases. I want to go to show here, when you have a distal type, they're anterior to the brainstem, and this is the location. Kind of, if you look at it, it's between 7-8 and the 9-10-11 complex. So the approach in that case, I do more like a retrosigmoid, but wide, going down to the region of the subocciput in a way. And this is the view you get because the aneurysm is located in this area. So I go down to the transverse sigmoid because you really want to see as anterior as possible. In some of them, they're buried inside the brainstem. So that's the view you get when you get the approach. So I'll show one example of it. This is a left-sided, this is the transverse and sigmoid sinus. So you see how wide and posterior and inferior the approach. The first thing to do is to open the cisterna magna and get the spinal fluid drained so you can get some relaxation of the brain. And then once you do that, you have an approach which goes sub-occipital and retrosigmoid in a way. And the view becomes much more clear for seeing the most anterior part of the aneurysm. So this is the 7-8 complex. And again, those aneurysms are always located between 9, 10, 11 in this, from this view, and 7 and 8. So that's the arachnoid in between that space. And as we expose it, that's 7, 8, and this is 9, 10. And one thing about dissecting the posterior fossa, do a lot of arachnoid dissections, because as you go further, the view becomes more clear. So now you can see here the proximal vertebral, and you can start seeing the aneurysm viewed, and this is quite distal and buried into the brainstem. And now we can start dissecting to get it out. You can see this is the brainstem here, and the pica is coming here and going backward. And the distal vertebral can be seen on this side. And you can see all these nerves draped around it. So for this one, once we get exposure, this is a proximal clip on the vertebral artery, and that's the aneurysm. And that's applying the clip. It becomes clearly visualized in front of you. And again, the nice thing is there is a big window here between the 9, 10, 11 and the 7, 8. Once you dissect the arachnoid and you go down, you always try to visualize the choroid coming out from the foramen. And that's when you can get a good view. And this is the aneurysm clipped, and the pica is coming from down here. So the final view looks like that. You can see the aneurysm pushed back. That's distal vertebral, the pica coming from here, and checking the flow in all of them. And towards the end, that's the view you get. So you get a really large, wide window if you go as low as possible and anterior against your own. This is fibrin glue. I cover the brain with it, so it will protect it, and you can nicely peel it off at the end. You leave everything intact. That's a point I wanted to show. This is another one which is more distal as well, and that's how it looks. You see the same view. This is 7, 8. This is 9, 10, 11 down, and that's pica coming back, and that's the clipping. You can see the window, how wide, and you're looking directly into it, because they're really anterior to the brainstem in some of these cases. And nowadays with CTA, you can almost pinpoint exactly which one is this. You can see pica coming back and the vertebra going this way and coming down in a way. And that's the view you see at the end. So Michael mentioned about all this. He has a beautiful series of bypasses for them. He's one of the most experienced in the world now with reconstructing those. So I'll go quickly over the pericallosal aneurysms. These aneurysms are, they can be very nasty when they bleed. These patients can get very morbid. That's why I never underestimate them as well. And no matter how small they are. And when they present, the majority of them are in high grade. Now, I show this picture because these are very similar to, if you remember what we discussed about the middle cerebral artery aneurysm, the whole span of the bifurcation is involved, not only just at the division where the bifurcation is located. So that's why they're quite dysmorphic. They need to be reconstructed without compromising the flow in the callosomarginal and the pericallosal. Now they can be precallosal in this region. I'll show you a case. And then they could be pericallosal or subcallosal. In that case, the dissection has to be more long in a way. Again, you can see how dysmorphic they can be, involving the whole span of the bifurcation from anterior to posterior. 40% of those are, in my numbers, associated with other aneurysms. So very common with multiple patients with multiple aneurysm. This is an example, and this is a case where a more simple type because we can clip it directly. This is not usually the common scenario, but you can see the anatomy in a second. And this is once we finish it, you can see the pericallosal coming here. This is the callosomarginal. There's even a proximal branch, and that's finishing the clipping and making sure that it's all filling. Now, this is another case which shows the case. One point to say, I have seen dissections, and with all my respect to other surgeons, where the interhemispheric surface is really bruised. Sometimes these are very tough spaces to dissect, but if you take your time, you should be able to to dissect. And it is very nice when you do your dissection and you see the brain intact, like you go in and out and the brain doesn't know that you've been there. That's how you should dissect them. Take your time, very sharp, very high magnification. If you don't magnify well, you're not gonna end up with nice dissections. Now look at how dysmorphic this is. That's the point I was making. And in this case, we're trying to put the clip so that you can keep the anatomy preserved. And I'll speed it up some. So again, this is more straightforward. I really want to stress the point, you have to go in and out preserving the surface of the brain in these cases. Now this one is more dysmorphic and pre-callosal in a way. This is that's how you see it. It's quite large compared to the straightforward ones. Again, look at how much dissection you have to take your time. I like to use the knife, a micro knife. Usually follow these P4 branches down. They will guide you to kind of like, this is like a difficult fissure in a way in some cases. This is injecting water. Sometimes your anesthesia likes to use water dissection. It will help if the space collapses when you relax spinal fluid. So once you get the exposure, now you can see in this case, this is a precallosal one. So this is the proximal pericallosal artery. This is the callosomarginal, and this is the pericallosal artery. This is the genu of the corpus callosum. So in this case, you want to dissect from distal to proximal to get the temporary clip so that you can further dissect the aneurysm. Now this aneurysm cannot be underestimated. You have to visualize it fully. Otherwise, you will miss on it. And you will see in a second, you notice here how the whole base is dysmorphic. So this is the temporary clip applied from a distal view. And then we dissect the aneurysm. This part has a component buried into the cingulate gyrus that we will get it out in a second. So in this case, you're doing a little resection of the cortex, just like what you do with gyrus rectus removal to expose the aneurysm well. And I'll speed it up to show. You can see now this is how much larger the aneurysm is. I'm putting some cottonoids so we can kind of delineate the space. And then the rest of it is reconstruction. And this is the aneurysm being dissected. And you've noticed in my cases and Michael's cases, the clipping steps are more than one just step. We don't just clip and that's it. We dissect, we see 360 degrees around it. So that's why I like to say aneurysm clipping is a process. It is not a step in a way. So that's the temporary clips being removed. And then you inspect and see how much of the aneurysm is left and how much is. In this case, this is a clip that goes on the aneurysm. This catches the anterior underbelly. Like you see here, the clip is contained, and then there is still a posterior underbelly that you see here that we need to include. And now we put like another clip to catch this part. And there may be a little residual. Sometimes if you try to put a clip on it, it may end up with a compromising the flow in the bifurcation. That's the aneurysm being cut and making sure that it's filled. And again, I want to stress, this is a nice dissection process. Keep the brain as intact as possible. So these patients, when they're caught unruptured, they have really good prognosis. And to me, those are more prone to rupture, and you want to catch them earlier. This is the most common type of unruptured ones, were the ones associated with a group of multiple aneurysms in a way. This is another case. Let me see. So this is a rupture case. No, not this one. Let me see. This is a rupture case which has a large hematoma in the ventricle dissecting the corpus callosum. So I want to just show the points of what to do here. In this case, the first part we did is, once we get to the aneurysm, is to secure the aneurysm. So I'm putting the clip in the direction of the to secure the part that's going into the hematoma. Sorry. So once we secure it, and then you can, because these are very difficult brains, and the problem is ventriculostomy doesn't work because there is a casting blood in the ventricle. So the next thing is, this is the bleeding spot. I'm going to dissect it and try to get the hematoma out, which is, you'll see here. And now we'll get to the hematoma and evacuate it in the ventricle. This is the ventricle after. You can see the casted blood inside the ventricle. So we secured the aneurysm. Now it's an unruptured but incompletely clipped aneurysm. And then once we clean the ventricle, we come back to finalize our clipping. Now we'll come back to visualize what we have. You can see the bleeding spot was here, and there's still some residual aneurysm. And now we'll put a proximal clip, and then we'll do the reconstruction again. So why I'm showing this case, you have to establish a strategy so you can very early secure the aneurysm. And this is the bleeding spot, converted to an unruptured situation, decompress the brain very quickly, and then come back and finish perfecting the clipping process. Again, you can see here, this was a multilobular, it's dysmorphic, and you can see this underbelly on both sides. And that's what I meant with the picture I showed. They're not the aneurysms. It's interesting. Professor Yazig refused to call aneurysms neck and neck. He said there is no neck. He called it a dysmorphic base. So now I'm coagulating to reshape it. And then now we will try to put the final clipping. And see, I put the clip, I remove it, and you just keep working on it until you get the perfect kind of obliteration of the aneurysm in a way. And in this case, we reshaped it so that it will fit the clip. So, and that's how it looks once we're done. And so okay, I think I'll stop here. We've kind of covered all these aneurysms. A lot of things that I would show would become more like repetition. And there's a lot of scenarios that can be addressed. But I think when you review the cases we have done before, in this case, the pericallosal aneurysms, the advantage of the easiness of these cases is you don't have to deal with perforators. You have a little bit more room with temporary clips. You just have to be careful how to reconstruct them, because I have myself operated on several recurrences that were done somewhere else. And I have to say also, I have myself 2 recurrences that I clipped. They were kind of fusiformish. And if you don't clip the base well and reconstruct them, they can regrow. So, well, I think I'll stop here, give more chance for any questions. And I want to thank Michael for kind of joining me with this endeavor. And again, congratulate him on his book. Michael, this gave me the chance to read your book, because before every session, I reviewed what you have mentioned, so we don't have a lot of overlap. And I learned myself a lot from it, so it was a good experience.
Ali, I always enjoy watching your videos. I think for those who are used to just listening to what he has to say, you pick up probably 80%, but there's about 20% that he doesn't even mention, that there's stuff going on there that's worthy of notice, and there's just a lot of great little tricks there.
Good morning, sir. I have a question, sir. Hello.
Yes,
yes,
sir.
go ahead. Go ahead.
Yeah, sir. How much is the dentate nucleus preserved, or any risk to a dentate nucleus while doing the suboccipital craniotomy?
Can you repeat what you said? Sorry.
The
Go slowly.
The dentate nucleus, is it at any risk of damage?
No, the far lateral approach is
lateral
nowhere near the dentate nucleus. Dentate ligament, yes. Dentate nucleus, no. That's deep in the center of the cerebellum, and you don't need to worry about that.
So there's one more thing. It's a general question I like to put forward. The phases score is applicable on the risk of rupture. So how can we use phases score irrespective of its ethnicity? Like its major question were, the major countries were like in study version in Finland, in Japan, and in European countries. So how can we apply it here in Asian ethnic way? Because the risk of rupture, that study was conducted in those, or can we use a different parameter to assess the risk of rupture?
I did not follow exactly your question. Michael, did you understand exactly what the question?
Well, yeah, there's a point in the phases score that relates to Japanese or Finnish
I see.
nationality, but I think if you're outside of those, you don't get the point. So it is applicable no matter where you are. So there's no reason why you can't use it.
Okay, thank you, sir.
And is this alluding to unruptured aneurysms being considered for surgery? Is that what it is, Michael?
It's yeah, it's a predictor of rupture risk.
Rupture risk, yeah.
Rupture risk.
I have to say something. You know, as we deal with patients over time, each one of us with experience, we have that gut feeling. You know, if I go with Michael to his clinic and I sit with him, I am sure there will be cases he would tell the patient, you know, I just don't feel good about this aneurysm. I would like to do it, and the sooner the better. Because when the patients describe to you some symptoms, if somebody had no headaches and all of a sudden started having headaches, they have an aneurysm, it's one, you know, on the same side, you cannot ignore it. If somebody had an ictal episode, you cannot ignore it. There are certain locations that you cannot ignore. So you can use all these kind of information and try to measure it, but you have to keep in mind statistics are applied on populations, but our medical decisions are made on one person, and you have to commit there and then with incomplete data. So a lot of it comes from your experience, because you know, Professor Yazegil and I were trying to talk about, you know, expert opinion. And this is a massive amount of data. It's called subjective, but it's really not subjective. It's a large amount of objective experience that collects over time. And it becomes like a gut feeling in a way.
Before going to the questions in the chat, I have to thank you both for this great webinar, concentrated dose on aneurysm. And I believe it will be as a reference for all young neurosurgeons. Whenever they want to do a surgery on aneurysm, they will go back and review the videos and refresh their memories. I have a question about clipology. You know, when we teach residents and trainees on the live cadaver how to clip the aneurysms and deal with bleeding, I always ask them to train their non-dominant hand and try to apply the clips in their non-dominant hand. So do you advise that? Am I teaching them right, or this is not necessary?
Well, I have a strong opinion about it, but I'd like to hear Michael's first.
Yeah. My opinion is that you're wasting your time, Ahmad. You know, the dominant hand is dominant for a reason, and you know, particularly in situations of duress, we go to things that are most comfortable. I think, you know, I'm very left-hand dominant because I'm left-handed, and I don't clip many aneurysms with my right hand. Not to say that I couldn't. It's just that, you know, I just find the greatest comfort and the greatest amount of facility with my dominant hand. So I think what's more important than forcing people to be in a situation that they're not likely to use in that duress setting of a ruptured aneurysm is just to find ways to make your dominant hand more comfortable. And for my residents, we talk about the chair position, the relationship of the surgeon to the surgical field, manipulating the scope and the angles of the scope. I mean, there's so much that goes into a comfortable clipping that the last thing you want to focus on is your non-dominant hand having to do all that.
Okay, thank you. Dr. Krisht?
I will not add a word.
Okay, so I will stop.
Not add a word. I have a strong opinion about it. He said it. If I'm taking care of somebody and his life is at stake, I am not going to use except my best hand, and I want to be in my best control. There is, you know, there's nothing much about it. If somebody is going to call me disabled because I can't use my left hand, I am a safe disabled. No problem.
Okay. There is a question on the chat about any comment about the craniotomy for the pericallosal aneurysms, and is there a difference in approaching left pericallosals from right pericallosal?
No, the craniotomy is standard, and more recently, because we have it, I use navigation. It just kind of, sometimes the shapes of the heads are a little different. It will be nice to just land on where the aneurysm is. The only thing is, if the aneurysm is more that's a subcallosal type, you may want to be going more anterior. It's a longer dissection in these cases. It's kind of, if it's a rupture, it can be a little bit more demanding, but you just have to do it safely. So you want to make sure you expose the sinus so you can retract the dura well. And the rest of it is meticulous dissection of the interhemispheric space, and but it's more standard in a way.
Yeah,
Okay.
I think
we always do the right side.
the point is that if you have a left-sided pericallosal, you still want to go from the right side because you want to protect the veins in the dominant hemisphere. So you should always go right when possible. I think the big question always with these aneurysms is, do you go with the nose up in the neutral position, or do you go with the nose to the side so that the midline is horizontal and you have gravity to help you? And I think in my mind, anything that's at the genu or distal, you can go with the head turned and the midline horizontal, and gravity will help you split that fissure. Anytime you're proximal to the genu, then you really need to go nose up and use the low bifrontal crani to get underneath the genu and get proximal.
Okay, well, thank you. I don't see any other questions on the chat.
Doctor, can I speak?
Question. Please, Omar.
Thank you. Thank you, Dr. Ali and Dr. Michael, so much for this webinar. I ask at pericallosal aneurysm and a critical space, can we wait? How much time can we have to wait and observe the patient if minimal symptoms and signs? Thank you very much.
Well,
yeah,
go ahead, Mike.
I don't wait if it's a subarachnoid hemorrhage. I think the key is early surgery, lower the risk of re-rupture, and get them out of danger as quickly as you can. So I don't think there's a reason to wait. It's true that if you let the brain simmer down and the edematous fissure gets more normalized, then it's going to be easier. But I think you're adding risk by waiting.
Yeah, I agree. And to clarify one thing, Professor Yazegil was the first to have introduced early surgery of aneurysms, because prior to him, the recommendation was wait 2 weeks before you do surgery because the morbidity was very high. And he tells me the story that when he presented his series and how he did things, a lot of people attacked him and they said, you're dangerous and you're going to cause people, a lot of people to die, because a lot of people are going to do surgery on very bad situations. And he was misunderstood. What he said at that time, that any patients who have hydrocephalus, any patients who have aneurysms that are in the basal part of the brain, any patients who have hematomas, and if you use micro technique, you should be able to get better outcomes in these patients. The things that they were alluding to is patients who are morbid, grade 5, or they're in very bad shape. There's a question whether to do them or not. But nowadays, I think with all the techniques of exposure and relaxing the brain, like Michael said, you're just adding risk. Now, if you're gonna do, rough surgery, whether you wait or you don't wait, you're gonna do rough surgery. if you're doing meticulous microsurgery, there's no reason that you're going to add injury if you do it early.
Thank you so much, Dr. Alia, Dr. Michael.
First of all, thank you, Professor Lawton, Professor Krisht. This is really great webinar. And Abud, your aneurysm model is incredible too. I want to ask you, professors, what do you think about semi-sitting position to pike aneurysm? Because Professor Oliveira used to do it in semi-sitting position, and we enjoy it a lot.
Michael showed how he does the incision. I do exactly the same, like a hockey stick. And then I put tack-up stitches to pull them down. And you get everything in front of you. And I'm sitting and got the right ergonomics, and you get the exposure. I know I used to talk to Evandro, and I have seen Evandro operate in a sitting position for some cases in AVMs for hours. And somehow he was able to hold his shoulders up. I get tired if it's very, very long surgery, but this is usually not demanding. I think it is good. I'm sure you have more relaxation of the brain, but in that corner, the brain is not in the way. And like you've seen in the pictures, you just gently hold up the cerebellum and you're there. The space is there. But there's merit to it, I'm sure. If Evandro uses it, there's something that is good about it. He's my teacher.
I don't use it for the far lateral. I actually think if you sit the patient, there has to be some reason for it. And usually it's to get gravity to retract something for you. In this case, there's no advantage to gravity retraction. You're not going over the cerebellum, you're going under it. So gravity actually doesn't help you in any way. And you have to remember that the far lateral has a lot of venous risk. If you've got an occipital sinus, or if you've got a marginal sinus, or if you get into the sigmoid sinus jugular bulb junction, and you get entrainment of air in the sitting position, it's a problem. So frankly, I think it's probably not advisable for this pica aneurysm in particular.
Thank you.
Okay, well, I think we will wrap it up here. Again, thank you for all the audience for joining us, and special thanks for Michael for this nice partnership, and hopefully we'll make plans for other things in the future. And thank you for the maestro of the Neurosurgical TV for putting this together. I appreciate all your efforts and giving the opportunity for other people to be able to view those videos. And I hope we were useful. And if we said something you don't like, we apologize.
Well, Ali, I want to show you your work is appreciated in China. And thanks to Dr. Lee, who's been doing the translations. Since you started the series, you got 20,039 hits in China. So your work is appreciated in China. So thank you. Thank you, Doctor. Thank you.
Thank you.
Thanks, everybody.
Thank you.
Okay,
Michael,
good night.
Thank you all.
Yeah.
Okay, very good. Very good.
Thank you.
Working. We expect an on-demand lecture of this informative lecture. I will review by YouTube. As a matter of fact, I'd like to like Chinese, so we have translation in Japanese. So hopefully, I would like to join later.
So, what's the next webinar? You mean?
Next webinar. So yeah, hopefully we would like to translate in Japanese. Most of Japanese neurosurgeons are interested in that.
Well, you know what, Takashi? Did you see the numbers I put up on the screen?
Yeah.
Yeah, you saw them, right? 20,000 since it
Yes.
started. So there's a bit, and I looked at the other videos to compare. It's far and away more. That series was far and away more than the other one, other webcast. So yeah, you're gonna do Yuha, right? In about 12 hours, right?
Yes.
Yeah.
This evening, because since I'm despite of my night shift, so I'd like to join 9 p.m.
Okay.
Thank
Very
you.
good.
Very good.
Very
Thank
good.
you. So
Yeah.
I go to work. Thank you.
Okay. See you tomorrow.
See you tomorrow.
Okay.
Tomorrow. Thank you very much for Dr. John, Dr. Takashi.
Okay.
Dr.
Thank you.
Muhammad Sharbini.
Thanks for coming and asking a question.
Thank you.
Good day, everybody. Anybody else want to introduce themselves or meet somebody or just say hi? You know, eventually, Eric, I didn't get to ask your question. Azadeh, are you there?
Hi, yes.
Yeah. What'd you think, Azadeh?
Yeah, that was great because I haven't any experiences with neurosurgery, and I really learned many things. Thank you.
Are you ready to operate?
Yeah.
Just grab a scalpel.
Dr. John, she needs aneurysm box.
That's right.
Aneurysm box.
That's
for
right.
her.
Upsurgeon.
Yeah.
Yes.
That was great. Thank you. Thank you, everybody.
Yeah, that was that's top shelf aneurysm teaching.
Yeah.
And as a day in China, they had 20,000 hits on it.
Wow.
Did you see that? I showed it. Did you see the?
Yeah.
You saw that, right? So
Yeah.
that 20,039.
Wow, that's great.
Yeah, so this people are interested in it. I think it was very good. You know, they decided the structure of having a series. You know what I mean?
Yeah.
So it's kind of like a theme that ties all six together. So I think that may be an attraction too. It's like a series all together.
Yeah.
So anyways, your camera's not working. Are you in a place where you can't really use it?
This is here is so late at night.
Yeah, no problem. No problem.
Yeah,
No problem.
that's why.
Yeah, a lot of people don't prefer not to have cameras, which is fine. Okay, very good. Very good. You know, we got to work on that as a day. I think doing little intros to videos is a good idea.
Yeah.
You know what I mean?
Great idea.
Yeah, just to say a few words, 30 seconds.
Yeah.
Makes it a little more interesting, I think.
That works better.
Yeah, but we'll talk about that tomorrow, okay?
Okay.
Okay, I got to promote now. There's a conference. Hey, let me show you. There's a bunch of people here. So let me show you guys what's going on.
11 hours tomorrow. There's
one in a couple hours from Indonesia.
Indonesia, yes.
From Bali.
Yes. Okay. Bali,
yeah.
And it's near Australian.
Near Australia, right?
Near Australia for those very too much good cost for swimming there. Bali
looks beautiful. Okay, there's traumatic brachial plexus injuries. And
the GMT
and all this news is on neurosurgical.tv. All this news. Okay, this is on. Yeah, it's 2:00.
Dr. John,
2:00
sorry, please.
Indonesia.
Can we put, Dr. John? Can we please put GMT? Is better for us.
The what?
GMT times, the time zone. GMT, London, Greenwich.
Time.
Yes, time.
It's on. Yeah, it's on.
Too confusing.
It's on the Facebook page. It's on the Facebook page.
God willing.
You're a follower. You're a friend of me.
Yes.
Everything's on the Facebook page all the time.
Okay.
And
All
the
the time. Okay.
conferences. You know, John Bennett, you're my friend.
I know you. You are my teacher, my
That's
father.
right. Okay,
Dr. John.
my father. I'm your
My
son.
father, yes.
My father.
Thank
Jesus
you,
Christ.
thank you very much for you.
I'm not that old, but
Thank you.
yeah, go to that page, John Bennett. Everything is there.
Okay. Thank you very much for you.
Conferences. I gotta go. Hi, Ibarra. How you doing?
Yeah, I'm doing fine.
Where are you from? Where are you from?
From Nigeria.
Oh, welcome. Did I meet you before?
Yeah.
Oh, okay. Very good. Welcome.
Mm-hmm.
You're a budding neurosurgeon, right?
Yeah.
Good. Excellent. Well, it's a
Thank
good
you very
time.
much.
Well, it's a good time. Just come to all our videos, or come to all of them. We have one on the brachial plexus in a couple hours, and then we have another one. Let me see, show everyone else this too.
Dr. John, I
Yeah.
have three brachial plexus operation this month. I prepare it.
Okay.
I can operate it at Egypt City, Syria, you know.
Okay, let
I
me.
prepare it but I haven't any microscope. I have a loop. I work.
You need upsurgeon.
Yes.
Okay, here. Okay, this is going on now. We're broadcasting this now. Let me show
Now
you.
this.
Yeah.
Now
Yeah,
this.
yeah. Let me show you where it's broadcast. I should put that on now.
Yes. Can we enter? Can we enter now? What is this?
Yeah,
Professor Mufti?
I better get going. I better get
Okay.
going. Okay, everybody. Over. Good night.